Module 1. Introduction. It's well known that opioids are a public health crisis across North America. News articles about fentanyl and opioids dominate the headlines. We commonly hear of opioid poisonings and encouragement for naloxone use. Professional organizations are cracking down on opioid prescribing. The government of Alberta is putting resources into creating the Opioid Emergency Response Commission, supervised consumption sites, and more ODP clinics throughout Alberta. There were 158 deaths from fentanyl-related poisonings in the first 3 months of 2018. Opioid poisonings contribute to significant emergency department visits. These are costly and take up many resources. Drug Analysis Service from Health Canada looks at drug samples submitted from law enforcement agencies. They found that fentanyl is the most commonly identified opioid in Alberta, at least 3 times higher than oxycodone or heroin. Despite identifying these issues, fewer than 1 in 5 individuals with opioid use disorders receive treatment. A few definitions to start. Tolerance is adaptation where exposure to drug induces changes that result in diminution of drug's effects over time. In summary, you need more drug over time to maintain the same effect. Analgesic and euphoric tolerance develops more rapidly than respiratory depression tolerance. This poses a problem if individuals are abusing opioids for euphoria. Higher doses are needed for the euphoria, but high risk of poisoning occurs due to respiratory depression. Physical dependence is an adaptation that is manifested by a drug class-specific withdrawal syndrome, produced by abrupt cessation or rapid dose reduction, or the administration of an antagonist. In summary, your body adapts to the presence of the drug and will experience withdrawal symptoms upon rapid discontinuation, or if the drug is not there anymore. Assume there are 100 patients with chronic pain. If you give an opioid prescription to each patient, you would expect that 100 of these 100 patients would develop tolerance and physical dependence. It is to be expected with every single opioid prescription, and it's not a bad thing. This differs from addiction. Addiction is a chronic disease influenced by various genetic, psychosocial, and environmental factors. It's commonly identified through the 4 C's. These C's stand for craving, compulsion, loss of control, and continuing despite consequences. Addiction occurs in 8 to 12% of chronic pain opioid-treated patients. Assume the same patient group as before. You have 100 patients who are treated with opioids for chronic pain. You would expect between 8 and 12 of these patients to develop opioid use disorder, or OUD. But all patients, 100 of the 100, would have physical dependence and tolerance to an opioid. Misuse and abuse have various definitions and may occasionally be used interchangeably. Misuse is the use of a substance that does not follow medical indications or prescribed dosing. This may be intentional or unintentional. Abuse is the use of a substance for non-therapeutic purposes to obtain psychotropic, for example euphoric, effects. It may or may not be harmful, especially in the short term. The takeaway is that these terms are distinct from addiction, but they may be used to describe addictive behaviors. Opioid use disorder is a chronic relapsing condition. It is often stigmatized by the general population, and this may affect individuals trying to seek treatment or their self-perception. It should be treated like any other chronic condition. It may be relapsing and remitting and associated with significant morbidity and mortality. It's important to screen a patient regularly, especially those who are on a long-term opioid prescription. For example, you may ask, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? Depending on their answer, it may then be wise to check and see if they fit the OUD diagnosis criteria from the DSM-5. Depending on the number of criteria they match, they will be classified as mild, moderate, or severe. Note that tolerance and withdrawal are included criteria in the diagnosis. This does not include chronic pain patients using opioids for analgesia. There are many different risk factors for developing OUD, and this is by no means a comprehensive list. Many SUD are strongly correlated to prior trauma. Oftentimes, SUD is a comorbidity to other psychiatric conditions, for example, schizophrenia or depression, and these contribute to significant morbidity and mortality. OUD is not limited to a particular socio-economic class and can be found in almost every demographic. Chronic pain is another common risk factor discussed in the next slide. Close to 20% of Canadians live with chronic pain. Opioids are used by 13% of the population. Within the chronic pain population, between 15 and 25% either misuse and/or abuse or display addiction behaviors. Close to 62% of patients had a chronic pain condition prior to OUD. The diagnosis of OUD in chronic pain patients is a complex process. Chronic pain patients may be using opioids for legitimate pain syndromes. However, some in this group may be abusing the prescriptions and using it for psychological benefit. Although some do not fit the OUD DSM-5 criteria, there may be a drug-seeking behavior or abuse issue within this population. To summarize, tolerance and physical dependence are expected in most, if not all, chronic pain patients and OUD patients. Both groups will experience withdrawal symptoms when discontinuing an opioid, but management of withdrawal will differ between the two groups. For chronic pain patients, a slow opioid taper may minimize withdrawal symptoms when trying to discontinue an opioid. Chronic pain patients may continue to use opioids to prevent withdrawal symptoms due to physical dependence, but this is not addiction. Chronic pain patients who do not want to taper off opioids may benefit from an opioid switch for better efficacy. The Rural Opioid Dependence Program, or RODP, has shown good results with chronic pain patients on Suboxone. However, this is beyond the scope of this presentation. Due to the complexity of OUD being a chronic disease characterized by the 4 C's, a slow opioid taper is not always a viable option. Withdrawal management, using for example buprenorphine, methadone, or other adjuncts, may be required. OUD is a chronic disease and will likely require long-term or lifelong management with pharmacological and/or psychosocial interventions. Simply put, harm reduction is acknowledging that people may or may not continue to use a drug, and that we should have programs and practices in place to allow them to use in a safer way in order to minimize long-term health consequences. Harm reduction plays an essential role in every stage of change and in the OUD treatment algorithm. Common arguments against harm reduction services are that it promotes consumption, or that consumption will increase. However, evidence has shown that this is not the case. Harm reduction may increase intake into addiction treatment services and reduce rates of HIV, hepatitis C, and opioid poisoning deaths. So far in Alberta, there have been no deaths on supervised consumption site property. Many harm reduction services are currently available. For someone wanting treatment, an opioid agonist therapy, like methadone or buprenorphine and naloxone, is the most common harm reduction strategy. If individuals are not ready for opioid agonist therapy, encourage other harm reduction measures. For example, a list of available needle exchange sites and supervised consumption sites in Alberta are in the resources section of this presentation. Clinicians should advise all patients about poisoning prevention education in case of relapse or continued use. Discuss tolerance with patients that have had any period of abstinence and the risks associated with use post-abstinence. Strategies could include never using alone, using test doses, avoid mixing drugs, and have naloxone handy and make sure someone is ready to call 911 at the first sign of poisoning. The importance of harm reduction from various community members is discussed in this video. Harm reduction is a valuable strategy. It's very difficult to just say, I'm going to stop using drugs starting Thursday. It's impossible to do that. There are a number of stages a person has to go through. I think with harm reduction, what you're doing is you're eliminating other things that are making the treatment much more complicated. So, for example, if you have a clean injection site where you have access to clean needles, you're not exposing somebody to the potential for an HIV infection or a hepatitis infection. So that allows you to focus more on the actual issue of drug use and abuse without all of these other confounding factors. So we want somebody who is not taking on other risks besides what's happening with their drug use. The same with naloxone. It may be very difficult to convince people not to take drugs, but if they do make mistakes, if they do have an accident where there's an overdose situation, naloxone will save that person. And with the way fentanyl is present in drugs that you're not expecting to have fentanyl even, it's important to have harm reduction things like naloxone available to the general public. So what you're trying to do is say that we want these people to be treated if they want to be treated, but let's try and concentrate on the drug situation. And we don't want that person becoming sick with other infections through unsafe drug use. And we don't want that person accidentally overdosing if we can prevent it. And that's where naloxone comes in. It is important that clinicians understand stages of change as they relate to OUD. Individuals with OUD may be at varying stages of change, and you cannot push someone into a certain stage. Identifying which stage your patient is in is important to foster a good working relationship. In the pre-contemplation stage, you might hear, "I'm not ready," or "I don't have a problem," or "I can quit anytime I want to," but do not push. You can advise that you will be there if and when they change their mind, and in the meantime advocate for harm reduction options, for example, obtaining an naloxone kit. Your goal in this stage is to start to develop a relationship and teach harm reduction strategies. In the contemplation stage, you might hear, "What do you think?" or general ambivalence. You can use motivational interviewing techniques to explore the ambivalence. What do you like or dislike about using? What would you like or dislike about stopping? Try to end with, what would the benefits be to stopping? So that is their takeaway message. Your goal is to further develop the relationship, discuss harm reduction strategies, and provide information on supports for them to check over on their own time. The determination stage is also known as the preparation stage. It is the most commonly missed stage, as people often jump from contemplation into action. As their PCP, it is important to discuss and consider factors like housing, income, and social supports to support recovery. Not considering these factors can result in early relapse, for example, entering treatment for OUD, but returning back to homelessness and street family who may use substances. Your goal in determination and/or preparation is to help them strategize their recovery and set themselves up for success. If you are unable to help with this, please ensure that you refer them to someone in the community that can. The action phase is where change happens. It can be any change: abstinence, decreasing use, using more safely, etc. Your goal is to encourage and support their change, regardless of how big or small. And remember that any change is positive and a step in the right direction. Small successes build confidence to make bigger changes down the road. In the maintenance stage, individuals try to maintain the change. For example, if the change was to start buprenorphine and naloxone, then continue treatment. OUD is a chronic condition. Other supports are needed to sustain recovery during the maintenance phase. Refer to addiction treatment resources, psychologists, addiction counselors, support groups, anonymous meetings, and community supports to maintain housing and employment. Relapse can occur at any stage, and your client may re-enter at any stage. Some may go back to pre-contemplation, and some may return to the action stage. It varies with the individual, so tailor your response and therapy as needed. This is just a reminder that the model is called the stages of change, not the stages of abstinence or quitting. Change can be anything and is up to the individual to decide. Change does not mean abstinence or opioid agonist therapy like methadone or Suboxone. Approach patients from the perspective of harm reduction. Adapt to their current views and level of readiness. Wherever the patient is on the stages of change, clinicians should encourage patients to make any positive change. Positive changes can include using more safely, for example, going to supervised consumption sites where there are clean supplies and other people in the event of a toxic dose of opioids, carrying a naloxone kit, switching the route of administration from IV to inhalation. Always discuss relapse harm reduction strategies, as it is very common to relapse, and this does not mean failure.